Giuseppe, thank you so much. And Valerie, that was a terrific lecture. It's an honor to follow you. So I was asked to speak on diagnosis of HCC, LI-RADS 2017, why we need it. My disclosures are shown here. So the title of my talk is LI-RADS 2017, why we need it. So I think probably all of you can guess what the goal of my lecture will be. The goal of my lecture will be to convince you that we do in fact need LI-RADS. Hopefully I will succeed, but we can debate later whether I succeeded or not. So how will I convince you that we need LI-RADS? Here is my outline. First, I'll go a little bit quickly over what it is. I'll talk a little bit about how it was created. And I'm going to go kind of fast through these two topics, so forgive me if I go kind of fast through those first two topics, because I want to spend the most time on topic number 3, which is why we need it. So let's start with what is LI-RADS. So LI-RADS is a system for standardization. It has an algorithm that comprises a decision tree and a diagnostic table. This algorithm is supported by an atlas of illustrative examples, by a lexicon of precisely defined and controlled terminology, and the system is indexed and hyperlinked. As Valerie emphasized in her lecture, LI-RADS applies only to patients at high risk for HCC, which in the year 2018 is thought to include patients with cirrhosis, patients with chronic viral hepatitis B, or patients who, for whatever reason, have declared themselves to be at risk for having HCC because they have had HCC in the past, even in the absence of these other risk factors. LI-RADS should not be applied to patients without these risk factors. It should not be applied to children because LI-RADS has not been validated in children. And for reasons that I don't have time to discuss today, it should not be applied to patients with vascular disorders such as Budd-Chiari or to patients with cirrhosis due to congenital hepatic fibrosis. Now, LI-RADS addresses the entire spectrum of HCC imaging. Here is an algorithm that displays how the various LI-RADS algorithms fit together. This slide is a little bit busy, so let me emphasize a few points. LI-RADS now has a system for ultrasound screening and surveillance, so it addresses detection. LI-RADS also addresses diagnosis and staging. Notice that LI-RADS applies to contrast-enhanced ultrasound as well as to CT, MRI with extracellular agents, and MRI with hepatobiliary agents. And LI-RADS also now has a system for assessing treatment response. So it assesses the entire spectrum of HCC imaging. Today we'll focus on diagnosis and staging. Now, for diagnosis and staging, LI-RADS begins with the quote-unquote observation. An observation is something in a cirrhotic liver that looks different than the background liver. So the observation that we see here is this small nodule which looks different than the background liver. For purposes of LI-RADS, we note that the background liver is abnormal, we note that there's cirrhosis, but we then ignore it and we focus on the observation. In this observation, we look at imaging features such as arterial phase hyperenhancement, washout, the presence of a so-called capsule, size, growth, etc. And based on these imaging features, we then assign a LI-RADS category, and the LI-RADS categories are listed here. I'll review the categories in just a moment. The first question that you might ask is, why do we assign categories? Well, ideally, we would not assign categories. Ideally, we would assign the exact probability of malignancy. And maybe someday when we saw a lesion like this and we saw that observation, we would be able to say, we would be able to put that observation on this continuous spectrum of probability from benignity to malignancy and say that lesion has a 99% probability of malignancy. And, as Valerie said in her lecture, because HCC is not the only malignancy in the cirrhotic liver, ideally we would also provide a probability of the cell type. the probability that the lesion is of hepatocellular origin, ranging from non-HCC to HCC. And for this lesion we see before us, we would be able to say that this lesion has a 98% probability of being HCC. That would be ideal, but we do not have the knowledge in the year 2018 to provide information with that degree of granularity. So instead, what LI-RADS does is it assigns categories which reflect the relative probabilities of HCC or other malignancy. LI-RADS 1, definitely benign. LI-RADS 2, probably benign. LI-RADS 3, intermediate probability of malignancy. LR4, probably HCC. LR5, definitely HCC. And then LRM, a very important category. This is a lesion that has features of malignancy. It is either probably or definitely malignant, but it does not have imaging features that allow the non-invasive diagnosis of HCC to be made. And as I'll talk about later, LI-RADS M lesions usually should be biopsied. LR-TIV, another very important category. This is a tumor that has actually invaded the vein. TIV, tumor in vein. And a new category, LR-NC, not categorizable. Now, with these various categories, LI-RADS addresses the entire spectrum of observations that can be encountered in the cirrhotic liver. And as illustrated in this cartoon, it is a very large spectrum comprising not only cirrhosis-associated hepatocellular nodules, but as a spectrum of additional malignant benign lesions, as well as some lesions that are not lesions at all. They are pseudo lesions seen only on imaging. Now, as an example, let's take this case over here, a 54-year-old man with cirrhosis. Does this patient have an observation? Yes, this patient has an observation, and we can measure this observation, and LI-RADS tells us to measure from outer edge to outer edge. This observation is 18 millimeters. This observation has arterial phase hyperenhancement. The hyperenhancement is diffuse, not rim. That's important. This lesion washes out compared to background liver. The washout is diffuse, not peripheral. That's important. And this lesion has a delayed enhancing capsule. LI-RADS then gives us this diagnostic table, and when we look at this table, we can realize that this lesion has arterial phase hyperenhancement, so we put it into this set of columns. The lesion measures 10 to 19 millimeters. We put it in that column. The lesion has both washout and enhancing capsule, so it has at least 2 additional features, and we put it in this row, and we can now say that this lesion is an LR5 or definitely. Okay, so I've spent a few minutes talking about what LI-RADS is. Let me talk just for a few moments about how it was created. LI-RADS was initially created in 2006. An embryonic version was developed at 2 institutions in the United States, one in San Diego and one at Thomas Jefferson in Philadelphia. In 2008, the American College of Radiology convened a committee to further develop LI-RADS, and in 2011, LI-RADS version 1.0 was released. At that point, it applied only to CT and MRI with extracellular agents. 2 years later, version 2013 was released, an algorithm was created, an atlas was created. The system still applied only to CT and MRI with extracellular agents. In 2014, hepatobiliary agents were added, the algorithm was simplified, and in 2017, lots of things happened. Ultrasound screening was added, contrast-enhanced ultrasound diagnosis was added, treatment response assessment was added, the algorithm was further simplified, and a manual is now in development. Now, I won't belabor the point, but at each time point, substantial updates were created as illustrated here. We anticipate the next major update will probably be in about 2020 or 2021. Now, also important that LI-RADS has been developed by a growing consortium of radiologists. In 2006, there were 4 radiologists that were involved in its development, and over time the number of radiologists has increased. There are now over 250 radiologists from around the world contributing to the refinement and development of LI-RADS. Now, LI-RADS was developed based on a blend of evidence, expert opinion, and a desire for congruency with other systems. So again, LI-RADS was developed based on a blend of evidence, expert opinion, and a desire for congruity with existing systems. And it is this blend that led to the development of LI-RADS. Now, some of you are probably wondering, why was LI-RADS created on expert opinion and a desire for congruency? Why wasn't it based only on evidence? And there are two reasons why LI-RADS was not created based on evidence alone. One is that the evidence simply did not exist. But two, and this is the sadder and more disappointing part, often the evidence did exist, but it was written in articles that did not use standardized terminology. And just like the Tower of Babel led to the proliferation of languages that people did not mutually understand, the radiology literature has had non-standardized terminology which did not allow the appropriate data to be extracted with the required granularity to create LI-RADS. So in the last 10 or 12 minutes or so, I'd like to now focus on why we need LI-RADS. I'll do this in the top 10. So we'll go over the top 10 reasons we need LI-RADS, starting with number 10. We need LI-RADS because hepatocellular carcinoma is important. As mentioned by Valerie and Giuseppe, HCC is now the second leading cause of cancer death worldwide, second only to lung cancer. As Valerie said, HCC is the fastest growing cause of cancer death in the West. If we look at the United States between 2010 and 2014, at the top 15 causes of cancer death, we see that liver cancer is not number 2 in the United States, it's currently number 7. But if we look at the annual percent change over time, this is what we see. In the United States and in Western nations, the number of patients dying from all cancers is decreasing with only 3 exceptions. One exception is pancreas, one exception is brain. The changes with those are minor. Look at liver. The annual percent increase of death due to HCC is increasing faster than that of any other cancer in the Western world. Number 9, why do we need LI-RADS? We need LI-RADS because imaging of hepatocellular carcinoma is important. This has been mentioned before. Imaging can be used to make the diagnosis of HCC non-invasively. Liver biopsy to make the diagnosis of an HCC is not always necessary. This is unique in HCC. And to illustrate this, let me emphasize that patients may undergo a liver transplant and receive, this says chemotherapy, may receive immune suppression without biopsy for the rest of their life without biopsy confirmation. And to emphasize this point, I want to introduce you to my parents. Now, my parents are in their 80s and they're too old to undergo a liver transplant, but imagine your parents, your brother, your sister, your husband, your wife, your sister. Imagine someone you love. And this is what it means. What this means is that you can tell your loved one that you can receive a liver transplant and for the rest of your lives you can be placed on immune suppression because the radiologist is that sure that you have HCC. So that puts a lot of pressure on the radiologist to get this diagnosis right. Why we need LI-RADS, reason number 8. Hepatocellular carcinoma imaging is difficult. I already sort of alluded to this before, but in HCC typically arises in the cirrhotic liver, in which we have multiple lesions and multiple pseudo lesions, multiple segments, multiple imaging features, multiple images, multiple series, multiple time points, multiple modalities, multiple contrast agents, multiple treatments, and multiple contexts. Does anyone see a pattern here? Multiple, 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 multiple. This is complicated. So not only is it important, it is difficult. Why we need LI-RADS, reason number 7. LI-RADS improves clinical care. And to illustrate this, let me start with a story. LI-RADS started in 2006 with a complaint. The hepatologists and the surgeons at UCSD came up to me and they said, "We have a problem. We cannot interpret your reports. We don't even care if you're right or wrong. We just want you to be consistent and clear." And they were right. Our reports were terrible. These were the kinds of words that I used to put in my reports. Indeterminate, equivocal, suspicious, HCC should be considered, etc., 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 leading finally to the ultimate junk recommendation of recommend clinical correlation. If you are a clinician and you see an 8 millimeter lesion in the liver, what does clinical correlation mean? Are you supposed to palpate that? What are you supposed to do? So our reports were ambiguous, and our reports were not actionable. By comparison, LI-RADS facilitates communication. It facilitates communication between you and between the other specialist, the patient, and even the trainee. Because now with LI-RADS, we look at this lesion, and we can say this is a LI-RADS 4, probably HCC, and this is unambiguous, and this is actionable information. LI-RADS also permits individualized management. So here is the management algorithm associated with LI-RADS. I don't have time to get into all the details. I want to emphasize 2 points. Point number 1, only 2 categories need biopsy and not always. So LI-RADS 4, probably but not definitely HCC, often needs biopsy. LI-RADS M, probably or definitely malignant, not specific for HCC, often needs a biopsy. The other categories can be managed easily and well without biopsy. In addition, so most categories can be managed without biopsy. So these are all the categories that can be managed without biopsy. This is very important. LI-RADS allows individualized management. Systems that are binary are simplistic and they overutilize biopsy. So in a typical binary system, the radiologist either says it's either an HCC, yes, in which case we treat, or it's not definitely HCC, in which case it's a biopsy. But biopsies are often false negative, and patients that get into this biopsy loop often need 2 or 3 biopsies until a diagnosis is established. I would argue that individualized management is what we need, and LI-RADS provides an opportunity to do that. Reason number 6, we need LI-RADS. LI-RADS facilitates education. Now, this is my 15-year-old son, and he's struggling with his chemistry homework, but let's pretend he's struggling with a radiology textbook. I have actually seen a radiology article in which the following term was used interchangeably: capsule, fibrous pseudocapsule, pseudocapsule enhancing rim, the light enhancing rim, capsular enhancement, and perinodular fibrosis. No wonder my son is confused. The authors actually meant the same thing every time, but they were using different terms to mean the same thing. It's very confusing. So by adopting a common language, LI-RADS will help education. Why we need LI-RADS? Reason number 5. LI-RADS facilitates research. There have been nearly 12,000 articles on HCC imaging published in the last 30 years. I did this PubMed search just a couple days ago. These were the search terms I used. I found 11,900 articles, and notice that the number of articles is increasing over time. I did a back-of-the-envelope calculation. I believe these 11,000 articles probably involved over 4 million person-hours of effort. But because these articles did not use standardized terminology, most of these articles, despite their quality, are proof of concept. They do not provide enough information to extract data to support the formation of guidelines. They have not used standardized definitions. Each article, or not each article, but many of the articles have used non-standardized information. So LI-RADS provides a dictionary of radiology terms which actually explains the words we use so that we can all speak the same language and understand one another. And when we do that, LI-RADS will enable the creation of registries that will allow big data to be used to better understand and improve the quality of care that we deliver. Reason number 4 that we need LI-RADS. LI-RADS can be used by experts and non-experts. And why is this important? If you read the fine print, other systems specifically say that they are designed for experts only, or they provide different criteria for use by experts and for non-experts. So if you're sitting in this audience and you are not an expert in HCC, some of these systems are not intended for you. So by comparison, LI-RADS can be used by academic radiologists, community radiologists, trainees, and other specialists. LI-RADS does not care whether you're an expert or not. LI-RADS tries to make you into an expert. LI-RADS is for everyone. Why we need LI-RADS? Reason number 3. LI-RADS works. LI-RADS categories have different outcomes. So research is emerging in the last couple of years, and these articles have looked at the probability of HCC associated with LI-RADS 5, LI-RADS 4, LI-RADS 3, LI-RADS 2, LI-RADS 1. So I read these articles, and I simply added up the numerator and denominator for each of these categories as shown here. And then, and I have to give credit now to Maxime Renaud, because this is not his slide, but I took this idea for how to make this slide for him. So please, I want to acknowledge Maxime Renaud for his cleverness. So what I'm showing here is that LI-RADS 1, in the published literature, 0% of these are HCC. LI-RADS 2, 6% are HCC. LI-RADS 3, 36% are HCC. LI-RADS 4, 72% are HCC. And LI-RADS 5, 96% are HCC. So LI-RADS is actually working pretty well. It doesn't mean that it doesn't have room for improvement, but it's actually working pretty well. And similarly, LI-RADS M probably or definitely malignant. It turns out that almost all of them are malignant. In the published literature, 98% of LI-RADS M's are malignant, with about 50% being HCC and about 50% being other malignancies. Why we need LI-RADS? Reason number 2. If we don't do it, someone else will. Over 25 organizations have proposed criteria for the radiologic diagnosis of HCC. Here are the names of those organizations. So I want everyone to look at the names of these organizations that have proposed radiology criteria for the diagnosis of HCC, and what word is missing from the names of these organizations. The word that is missing is radiology. I would propose that a system for the radiologic diagnosis of HCC should be created by radiologists. Let's do a thought experiment. How do you think hepatologists or surgeons or pathologists would react if we as radiologists created guidelines telling hepatologists how to manage cirrhosis, telling surgeons how to operate, and telling pathologists how to interpret histology? It's not believable, and yet this is what's happened to radiology. Non-radiology organizations are creating instructions for telling us how to do our jobs. Why we need LI-RADS? Reason number 1, LI-RADS is a forum for international collaboration. LI-RADS now has over 250 members from over 30 countries. Shown here is a world map illustrating the relative representation of radiologists and other professionals that are contributing to LI-RADS. Over 30 countries are now represented. This is a photograph of the steering committee at the RSNA in the year 2017. This is one of many different working groups and committees within LI-RADS. If you are interested in joining LI-RADS, please email me at the email below. I don't care whether you're an expert or a non-expert. I don't care whether you like LI-RADS, love LI-RADS, or hate LI-RADS. The only thing I care about is that you're passionate about the liver. So if you are passionate about the liver and are interested in contributing and making LI-RADS better, please email me. So in the last 20 minutes or so, I've reviewed what LI-RADS is, how it was created, and why we need it. I hope that I've convinced at least some of you that we need it. For those of you who remain unconvinced, but if you love LI-RADS, if you love the liver, please email me and make LI-RADS better. Thank you very much for your time.